let me tell you how grateful I am to all of you for inviting me to join you. I am delighted to be included in this wonderful group of physicians and patients with a very rare disease, pyruvate kinase deficiency, the illness that brought me from adult medicine to pediatrics. That's a long story, and I'm not going to push you on that, except to say, when I saw my first case of pyruvate kinase deficiency brought to my attention by one of the finest fellows ever trained by Louis K. Diamond, one of the founders of pediatric hematology. His name was Frank Oski. And when Frank came with that case to show me and ask for my opinion, I practically fell off my chair. I couldn't believe the morphology of the red cells in that situation. I had never seen a slide like it. And that began my friendship with Oski, my fascination with inherited diseases in children, and brought me to the Children's Hospital, where I then joined up with the Dana-Farber Cancer Institute, and I've been here ever since. So this disease, pyruvate kinase deficiency, is the beginning of my entire career. Now, it has a very interesting history, both in the United States and in Europe and in Australia. These are very rare mutations in a gene that occur sporadically around the world in very few times. That's fortunate. Unlike sickle cell anemia, which is another disorder in children that is seen with much higher frequency, it's not affected by any other disease. It turns out that sickle cell anemia is actually protective against malaria. So the survivors of malaria have a very high incidence of sickle cell anemia. That's not true of pyruvate kinase deficiency. It's really not protecting you from any illness. It's a problem. It's a rare mutation, and fortunately it stays rare. It's certainly true that families who know they have carriers should of the mutation, and it takes 2 mutations to make the disease, should be wary and be testing partners for being carriers. But it's rare enough that it's really not a major public health problem the way sickle cell anemia is. However, it's a terribly important example of what can go wrong in the human red cell, and it causes a lot of trouble for when it occurs in 2 doses in any individual. Now, it was probably described first by the famous British hematologist John Dacey. It was also known by De Gruchy in Australia, but it certainly didn't come to my attention until a very important paper written by Bill Valentine, then in Los Angeles, who had been an excellent hematologist at Rochester before he moved to Los Angeles, actually described the enzyme deficiency itself. When I saw Oski's patient, I didn't know about Valentine's work. That was that new. That was back in the 60s. But I soon found out that Valentine had described it, and Frank and I set about to not only determine whether or not our patient really had 2 mutations in pyruvate kinase, and also went up to upstate New York to see how many other patients in the family from which the baby came, the child came, also were carriers. And that brought us together. We worked all night to get this enzymology done. And I remember the trip so well because we went with Dr. Diamond, who was an unforgettable character. And that trip was one of the most enjoyable ones I ever had. So I did want you to know that's my background in this disorder. Now, when pyruvate kinase deficiency was first discovered, actually, before it was even known about the enzyme, it was called non-spherocytic hemolytic anemia, because the red cells were not little round balls as they are in the much commoner disorder, hereditary spherocytosis. The red cells were just bizarre looking, but they were not round little spheres, which they are in that much more common disease. And furthermore, the hereditary spherocytosis is more or less a milder disorder. And it also had one very strange difference between itself and pyruvate kinase deficiency. Splenectomy in hereditary spherocytosis is virtually curative of the hemolytic anemia. It doesn't the red cell morphology, that is the sphered red cells, don't disappear, but they don't die early because they in an obligatory way, they die in the spleen. The spleen removes them completely. And in pyruvate kinase deficiency, it's just the opposite. The removal of the spleen is helpful, but instead of the blood becoming normal, in fact, it becomes more abnormal. And indeed, more young red cells appear in the blood. The bone marrow seems to be working harder when the spleen goes out. It isn't actually working harder, but something very strange happens in pyruvate kinase deficiency. And I don't want to bore this group with a lot of technical stuff, but the facts are, in pyruvate kinase deficiency, the problem is a mutation that blocks sugar consumption in the red cell. The red cell lives on sugar from the blood. It takes sugar up and it converts it to energy with a series of enzyme steps, all of which, by the way, can suffer from mutations. But the commonest mutation is pyruvate kinase, which is about a third of the way down the pathway of conversion of sugar to energy. So it blocks the conversion of sugar to energy. The young red cells have a different pathway. They not only have this long sugar pathway, but they also have energy machines called mitochondria, little particles within them that they retain because they're very young cells. And those little particles of mitochondria can create energy independent of pyruvate kinase. So the young red cells can live in pyruvate kinase as long as they are young. But when they lose their mitochondria, then they're a helpless red cell without that crutch, and they die immediately. And they tend to lose their mitochondria in the spleen when they have to travel through it. The spleen sort of plucks them out of these young red cells. And so what happens is if you take the spleen out of a patient with pyruvate kinase deficiency, the hemoglobin may rise, but the number of young red cells also rises. That's just the opposite of hereditary spherocytosis. In hereditary spherocytosis, you start with a number of young red cells in the blood because they're being destroyed in the spleen. But when you take the spleen out, the destruction stops, and so the number of young red cells disappear. In pyruvate kinase deficiency, there's a massive increase. And we showed years ago in the 60s with a wonderful young fellow named Bill Menser that this is all about the spleen, that the young red cells go into the spleen, they lose their mitochondria, but the number of them rises in the blood until they're finally destroyed in the liver. They're so weakened. Actually, young red cells need more energy than old red cells. Like young babies burn up a lot of energy running around. Young children, old people sort of sit in a chair. The old red cells are hanging around waiting to die. The young red cells are frisking around like lambs in a meadow. They need energy, and they get it because they're young. But then eventually they lose those mitochondria and they die. So there's a huge difference between the picture of the blood in pyruvate kinase deficiency than in hereditary spherocytosis. Now the question is, what's the treatment if that's the case? And the treatment has always been splenectomy because the hemoglobin rises. And we may have all these fancy explanations as to the differences between reticulocytes or young red cells and old red cells, but the facts are the patient does a lot better with more hemoglobin, even though the reticulocyte count rises. The young red cell count in the blood actually rises after the procedure. Is there a danger in taking out the spleen in pyruvate kinase deficiency? Well, we'd rather not take the spleen out of anybody because the spleen is a great particle remover in the blood. It is the vacuum cleaner of the blood. And it not only vacuums up abnormal red cells, it vacuums up bacteria. If you inject dead bacteria into the blood of an animal, the spleen will instantly remove them. They're foreigners, and the spleen knows that and gets rid of them. As a result, the spleen is an important organ because if by accident anybody gets an encounter with a bad germ, like say the pneumococcus of pneumococcal pneumonia, that's a very dangerous organism when it gets into the blood, and we rely on the spleen to get rid of it. So if we take the spleen out of somebody in order to have them have better blood and better hemoglobin, we're taking the risk that they may get an overwhelming bacterial infection and die of it. And people do die with people whose spleens are removed can die of very serious infections. But we have an answer to that too, because we know that if we give the right dose of what we call prophylactic antibiotics to people whose spleens are removed, we protect them from bacterial infection. So with that added protection, we feel it's safe to take the spleen out. Is that the end of the risk of splenectomy? No, because when you take the spleen out of a person whose bone marrow is very active, that means other blood cells may be circulating at a high level in the blood. And that includes clotting elements, platelets, the little tiny cells in the blood that initiate clotting. And one can get unwanted thrombosis or clotting illness from taking the spleen out. So sure, we'd rather not take the spleen out of anybody. And the great news was the discovery in a totally different field, cancer, that one could actually modify enzymes and make them work better by small molecules attaching to them. Now, I have to explain that, I have to ask you to think about enzymes for a moment. They are proteins made by genes, and pyruvate kinase is one of them, that look like a piece of spaghetti. If you cook a piece of spaghetti and then drop it on a plate, it'll curl up. You won't just see a long strand. It will curl up into a shape. And the sequence in a protein that is an enzyme, the sequence of the little subunits of that protein called amino acids that are driven by genes to assemble themselves in a certain order controls not only the sequence of amino acids, but also the shape of the spaghetti, if you will. Because depending on the amino acid sequence is the shape of the molecule. And it turns out that the shape of the molecule also defines its function. If pyruvate kinase has a particular function, a certain conversion in the step of modifying sugar to energy, and each step is controlled by a different enzyme. Pyruvate kinase is a very, very special enzyme in that pathway. The problem in many, many cases of pyruvate kinase is the sequence. The sequence is incorrect because of a mutation, and therefore the function of the enzyme is depressed. It turns out that small molecule can attach to the whole structure and change the structure more favorably so that it works better as an enzyme. And pyruvate kinase, to my knowledge, is the first example of a drug company actually making a molecule for a different reason. They were trying to modify the metabolism of cancer cells, but discovered this function and applied it to pyruvate kinase, and lo and behold, they came up with a drug that actually, in many cases, can modify the function of the enzyme and make it more effective, far more effective. And indeed, I watch in our clinics now patients who really were quite anemic, getting very well on this drug. And it's available to patients, not all patients, but to patients who have structural abnormalities due to a mutation. That structure can be pushed back toward better function by adding this drug to them. So a couple of pills a day, and suddenly the hemoglobin goes up. It's really quite wonderful to watch this, and I think it's a huge step. So, would we do a splenectomy immediately now in patients with pyruvate kinase? No. We would first determine whether or not the mutation is one that does respond to this drug. If it does, we won't touch the spleen. We'll just give them the drug. In some patients who have a splenectomy, they still get benefit from the drug, getting more hemoglobin if they've already had a splenectomy. So that's terrific. Now, the drug isn't useful if the mutation is so severe that there's no enzyme protein at all. That can happen, where it's completely deleted. But for the most part, this drug is really an enormous contribution. And for me, it was not in the 1960s when I first saw this illness. Never dreamt of a small molecule that could cure it. And now we're talking about gene therapy in a number of blood disorders. I wouldn't push that in pyruvate kinase right now, but there are better and better methods of gene therapy coming. Some of them that are on the table for investigation will not involve bone marrow ablation or damage in any way. That field is growing, and it's getting a lot of attention, and it may well be that in a few years this disease will respond to very simple injectable genes that will home into the bone marrow and correct this disorder. So medicine marches on, and I'm an old man now in medicine. I've seen a lot. I have complete confidence that my successors are going to see wonderful results. So one wants to be very cautious about splenectomy now. Be careful and be sure you want to do it, because the help is on the way. As far as parents are concerned, parents just have to be parents. They've got to make sure that their kid gets the best care possible and gets the best schooling possible. And all I can tell you is that I know a number of pyruvate kinase deficient patients, and they may be deficient in pyruvate kinase, but they're not deficient in kindness, decency, intelligence, and wonderfulness. So let's concentrate on what the strengths are and take care of the weaknesses later on. We'll get there with this disease. I can promise you that.